EOI, Endodontics, Oral Surgery, and Dental Implants Rehabilitation of New York City. Next Level Dental Care.
Today is the concluding one in the series of airway management, and that's going to end with a bit of an overview of sleep apnea. Valentina Lisova is my partner in the office in the EOI, and she's going to be what we call the course director today. She has two other good friends of ours that are going to help her. She's going to introduce them as well. Valentina is a prosthodontist who has had a very extensive training in prosto. What do I mean by that? So she did her NYU dental training, and then she did 3 years of prosto training at NYU, and then she decided to do an extra 1 year of prosthetics, maxillofacial prosthetic at Sloan Kettering, and then after that she did 2 more years of prosto training at Columbia with Dennis Tarnow's group, and she focuses now, she's limiting her practice with us at EOI to the surgical phase of prosthodontics only. She doesn't do any more porcelain work, she doesn't do any of the nitty-gritty of prosto, but she's focusing on the surgical part. We're going to give the microphone to Valentina in a few minutes, and Valentina is going to introduce her colleagues, our good 2 friends, Ilana and Kathy. But before turning over, I'm going to talk about 2 different things, 3 other announcements, and then I'm going to turn to Ida, who's going to give us the rundown on the house rules here. One of the things is that I wanted to welcome another friend of mine, Jamie Lee. I don't know if Jamie, you're on. If you are, just unmute yourself and say hello so people can see you.
Hello, it's good to be here with you all.
Hi, Jamie. Good morning. So
Good morning.
Jamie is an endodontist that just joined our office as of a few weeks ago. We're very happy and excited to have you. And with Jamie coming on board at our group, we now take all major insurances as well. And as I've said it before, we open 5 days a week as of now, taking care of emergencies. And then thank you, Jamie. The next item that we want to talk about is we actually finally did something right, and we have our next week's course ready as of now for me to introduce to you. Next week is going to be presented by a friend of our friend, Avi Shmuli. His name is Paul Zalentz. Paul is an infectious diseases specialist. He is, up to a few weeks ago, he was the head of infectious diseases department at ProHealth, which is a series of urgent care centers. It's a whole group of offices. And he was running the infectious diseases there. I think he left and he's at Northwell now. Being that he's an infectious diseases guy, we figure he's the most appropriate guy to give us valid information about SARS-2, COVID, and the new disease, I guess, MIS-C, that affects the children. Hopefully he can talk to us about the pathophysiology. He could talk about infection control, separate the facts from the fiction, so we know how to protect ourselves and how to protect our patients. Unlike me, I'm going to speak for myself. He has a day job now, and he's asking us to meet at 6 p.m. So next Tuesday, June 2nd, I believe, we're going to have our meeting from 6 to at least 7, possibly 8. From 6 to 7, he's doing his presentation, and I'm sure the dentists in the group have a lot of questions for him, so that will go to Q&A afterwards. So Paul will be in next Tuesday. Any questions that you have, if you want to hear it directly from an expert, that will be him. If you have friends that you want to invite to the group, please let them know as well. As far as taking attendance, that's the only other comment that I have to make today is we're going to do it a little bit more high-tech today. And at the end of the meeting today, around 11:45, in the chat room below your screens, or depending on how it is set up, there's a chat room within Zoom. We're going to send a link where you just have to click on it, put your name on it, and that will tell us that you were here. This way, during the presentation, Ida and I can also enjoy the presentation, and we don't have to write down people's names anymore. So around 11:45, close to 12 o'clock, look out for that link. We will announce it, then we'll release the link. Click on it and put your name on it. And that link will be active for the rest of the day, but not tomorrow, where you could sign in as well as an attendant. and that will allow you to get the credits. So let me pass the microphone to Ida. Ida, go ahead, and then we'll go back to Valentina. Thank you all.
Okay, so good morning, everyone, on my behalf as well. I'm Ida Piiranen, and I work here at EOI NYC with Dr. Dayani, Lusova, and Gleed. And today, Dr. Dayani already told a little bit about us, but I just want to mention as well that we are the Center for Endodontics and Oral Surgery and Dental Implants of New York City. And as usual, I will be the host today's webinar, and I will be hosting from our office. And I try to do my best to make this a good learning experience for all of you. And as this group by design is meant to be an interactive seminar, please feel free to ask any questions. For questions, I would ask that we would use as our advantage the Zoom chat feature, and it is located at the bottom or side of the screen. So in case if you have any questions, please post them there for all to see. Our moderator or panelists will then address your questions. And another thing that I want to mention is that I will be muting everyone during the presentation. So remember to unmute yourself if you're being called to ask your question. And I think that's it on my behalf, and I will turn this now to Dr. Lusova.
Good morning, everyone. You can hear me well, I hope. Let me know, Ida, if you can't hear me. Can you hear me?
Yes, we can hear you.
Okay, great. Okay. So today's presentation is on sleep apnea again. This is our third part. We had a tremendous interest from you guys on this series, and we decided to
sorry,
continue.
Yeah. The voice is going in and out, just so that you're aware of it.
Okay, let me see if I can. Can you hear me better?
It's getting better.
Is it better?
Yes.
Yes. Okay.
Yes,
so,
correct. It's better now.
Okay, great. Okay, so I broke down today's presentation into three parts, basically. First, Dr. Grossman is going to talk about some basics of obstructive sleep apnea. She's going to define some terms and give you an overview how to actually assess the patient with suspected sleep apnea. The second part is going to be a somewhat controversial topic of sleep bruxism and its correlation with sleep apnea. And in the third part, we're going to talk about some oral appliances, discuss their use and what's available and their pros and cons, and then we will open to Q&A. So let me start and present you Dr. Ilana Grossman. Ilana?
Good morning, everyone. I hope you all had a good night's sleep. Unfortunately, that's not possible for a lot of people due to sleep disordered breathing, which can cause social embarrassment as well as health complications. A little bit about me. I've been in practice about 10 years. I work both in private practice and at a psychiatric hospital. So I definitely see a disproportionate amount of people with airway disorders at the hospital. Commonly, when we think of the first symptom that we think of with obstructive sleep apnea is snoring, and that is often the reason why a lot of patients seek treatment. Sorry, let me get those shares. Lita, or who's ever in charge, could you let me share my screen? I'm still not able to share the screen. Is someone able to change that?
Okay, so while you're trying to get it to work, I just want to say a few words about Dr. Grossman. She graduated from Stony Brook of School of Dental Medicine. I'm sorry, and did her general practice residency at North Shore University Hospital in Manchester, right?
Mm-hmm.
And yeah, okay. Originally, she's from Long Island, New York. And again, as she mentioned, she works in private practice in Manhattan and resides on the Upper East Side. And she loves snowboarding, cycling, rock climbing, and she actually did 2 Ironman. So, is it working now, Lana?
It still says, who's the host? It still says the host is disabling screen sharing. So is that?
If you want, Dr. Grossman, I can try to share it.
Is there any way you could just enable screen sharing?
You should be able to screen share. There shouldn't be any restrictions for that.
Okay, it's saying host disabled attendee screen sharing.
Okay, let me make you a host temporarily, okay?
Okay, thank you. So commonly, a symptom that triggers patients to seek treatment is snoring, and that's often a complaint that a companion may have. So I'll give you a minute to read this comic, which I think sort of summarizes a lot of the problems that obstructive sleep apnea causes. It not only does it cause health consequences, which could shorten your life expectancy, but it could also drive the people around you crazy and can compromise relationships. A little bit about the epidemiology. It affects about 17 to 20% of people, and it's more prevalent in men than women, affecting about 1 in every 4 men and 1 in every 10 women. However, that gender disparity evens out as you get closer to menopause due to changes in hormones. Also, once you get over the age of 50, the prevalence in the population is closer to 50%. The reason behind that is as we get older, we tend to gain weight, and also we lose muscle tone, and the soft palate continues to grow. It's more prevalent than diabetes and asthma, but up to 80 to 90% of the cases are undiagnosed. Part of the reasoning is a lot of the health side effects are things like heart disease, diabetes. They're just diseases that are so common that a lot of people have started to think of them as normal, and they don't realize that it can be caused by obstructive sleep apnea. So sleep apnea comes from a Latin root. It literally means breath. So sleep apnea is when you don't have airflow through the throat while you're sleeping. For the purposes of a lot of sleep studies, it's the reduction of airflow by at least 90%, and it has to last at least 10 seconds to be considered an apnea. There's also something called a hypopnea, where you still have a little trickle of air, but it's not enough to get a good breath. It's similar to drinking a thick milkshake through a thin straw. You're getting some air, but it's not enough, and you're using a lot of effort. There's a couple of varying definitions, but it can be considered a respiratory flow reduction of at least 30%, and it has to last at least 10 seconds. Also, can you mute yourselves if you're typing or anything? Thank you. And it also could result in an oxygen desaturation of 3 to 4%. Again, there's some varying definitions. As a result of the decreased blood oxygen and the stopping of breathing, the parasympathetic flight or flight response stimulates the body to have these arousals, so you wake yourself up so you can start breathing again. But all these interruptions can affect quality of sleep. A little bit about sleep cycles. And one phase of sleep is light sleep, sort of when you're half awake, half asleep. And as we're asleep for longer, we progress into the N2, N3, and N4 stages of sleep, which are the progressively deeper phases of sleep, and REM sleep, which is when dreaming occurs. So REM stands for rapid eye movement, and it's the part of sleep when you do the most dreaming. And as a defense mechanism, your body's muscles relax. Otherwise, you might get up and start reacting to your dreams. As a consequence, snoring often occurs during REM sleep. Since your muscles are relaxed, the soft palate and the tongue can fall back into the airway. Patients who have obstructive sleep apnea spend a disproportionate amount of time in the N1 phase of sleep. because they're not asleep long enough because of all the arousals to go into N2, 3, and 4 and REM. So therefore, not only are they getting a reduced amount of sleep, but they're not getting a good quality of sleep, because the deeper sleep is where a lot of the restorative actions of our body occur. So without that, you don't have time to heal. A related syndrome is something called upper airway resistance syndrome. This is a syndrome where the breathing's impaired, but it doesn't quite fit the criteria for sleep apnea. If we traditionally think of obstructive sleep apnea as affecting older obese men, we think of upper airway resistance syndrome as affecting younger, thinner females. Just to be clear, you don't have to be obese or male to have OSA, but those are certainly risk factors, and the upper airway resistance syndrome isn't necessarily correlated with sleep apnea. You still have repetitive increased respiratory efforts that are terminated by transient arousals, but you don't have the associated airway collapse, hypoventilation, or oxygen desaturation. You still can have negative health consequences, and these patients may still snore. The way we measure sleep apnea, one way we measure sleep apnea is something called the AHI index, the apnea-hypopnea index. You simply add up the number of apneas and hypopneas, and you divide it by the number of hours slept. Under 5 of these apneas per hour is considered normal. 5 to 15 is considered mild sleep apnea, 15 to 30 is considered moderate, and over 30 is severe. For people with severe sleep apnea, usually CPAP is, just mute yourself if you're typing, please. Thank you. People with over 30 apneas per hour are considered to have severe sleep apnea, and the first line of treatment recommended is CPAP therapy. However, there's a high rate of what they call CPAP failure, so these patients still may benefit from dental appliances. Dental appliances can be the first line of treatment for mild and moderate. And even the patients who are considered normal, you don't want to just look at the number, because as we spoke about earlier, you could still have upper airway resistance syndrome. So you'll test normal on a sleep study, but you might still be complaining of snoring or daytime fatigue. So if you have a patient like that, it still might be worth trying a dental appliance, or what we call a snoring appliance, to help improve their quality of life. Sleep apnea has consequences on a lot of aspects of our lives. As I alluded to earlier, it affects relationships. Often if one partner snores, they end up sleeping in separate beds. It could affect intimacy. It can cause social embarrassment. If you're on a camping trip and you're keeping everyone awake, that can be embarrassing and annoying to those around you. And it has a lot of health concerns. But usually on average, someone with sleep apnea, you end up spending 2 times the amount on healthcare costs. And the life expectancy can be reduced by anywhere from 8 to 18 years. Other diseases correlated with it are heart disease, stroke, and type 2 diabetes. Sorry, I hear someone typing. Could you just mute yourself, please?
Ilana, I'm going to jump in for 1 second. Good morning, everyone. I know a lot of people joined in later when Ilana started talking. We were around 40. Right now, we're at 73. So welcome if you've come in. Usually, Ida does the hosting, and she can mute you whether you like it or not. But because the host right now is Ilana, and of course, she's making presentation, she will not be able to, we will not, and she will not be able to mute you. When you come on, it will take over the whole presentation. So try to mute yourself if you're not muted, and we'll continue. Sorry, Ilana, for the interruption. Please go ahead.
All right. Sorry. So since it's the parasympathetic system that triggers these frequent arousals, you end up with insulin resistant because of the frequent releasing of cortisol. So there's an increase in type 2 diabetes. So about 90% of the cases of insomnia are correlated with sleep apnea. And some more obvious ones, daytime fatigue. Daytime somnolence just refers to falling asleep during the day. This could be dangerous if you're driving, you could fall asleep, have a car accident. Also, any mood disorders that are correlated with sleep deprivation, such as anxiety, depression, general moodiness, are going to be worsened by obstructive sleep apnea, since, as I said earlier, you're not getting enough quality and quantity of sleep. So there's a lot of ways we could screen the patients before they even walk into the office. As I said earlier, a lot of them complain about snoring. In terms of obesity, specifically, we're looking at body mass index, and the two measurements we look at a lot are neck circumference and waist to hip ratio. So as I said earlier, it affects men at a higher rate because they frequently store fat in their neck, and that fat could wrap around the airway, causing an obstruction. Again, if they talk about daytime sleepiness, Kathy and Valentina are going to speak a little bit more about acid reflux and bruxism, but there's about an 8% higher incidence in patients with sleep apnea. Another screening question you could ask your patients is if they have to frequently get up to use the bathroom in the middle of the night, something called nocturia. And usually when we look into the studies, this is preceded by an apneic event. What happens is, since the parasympathetic system stimulates increased heart flow increased blood flow to the heart, and that causes the heart to release a natural diuretic. Sorry, I think there's a truck here that might be causing noise. Give me 1 second. That increased blood flow will trigger the heart to release a natural diuretic, and that causes us to have to get up and use the bathroom in the middle of the night. Also, ADHD has a high correlation with airway problems. Moving on to the clinical exam, I borrowed this checklist. It's called the Elliott Evaluator. So it was borrowed from Dr. Erin Elliott, and I included her link to our website, which has this on the supplemental materials. The patient doesn't have to have everything on this checklist, and I'm not going to focus on everything, but I will mention a couple of items. I'm not going to go too much into bruxism because it'll be spoken about more later, but certainly look for erosion and wear on the teeth. Since these patients might need to breathe out of their mouth more, you want to look for that redness and signs for maxillary gingivitis that can be caused by mouth breathing. Battered uvula, scalloped tongue, so you want to look for this red, beaten up uvula. Also, anytime the tongue's taking up a large part of the oral cavity, that could be a sign of an airway issue. So sometimes we see these crenations or what they look like bite marks on the tongue, so that could be a sign as well. What we call a turkey waddle. So these patients have a retrognathic mandible, and the hyoid bone, which is that U-shaped free-floating bone where the tongue and throat connect to, is in the incorrect position in these patients. Enlarged tonsils and adenoids. These, of course, obstruct the airway. Also, there's evidence that kids with enlarged tonsils, sorry, I think that truck's about to leave. Give me 1 second. Oh my God. You know, I'm actually gonna close the window. Give me 1 second. All right, that should help. So kids with enlarged tonsils tend to breathe out of their mouth more, and that leads to the development of a constricted or high arched palate. And as we all know, narrower palate, narrower airway leads to breathing problems. So the Epworth Sleepiness Scale is a subjective scale. So it doesn't, as dentists, we're not able to diagnose sleep apnea, but we can certainly screen for it. And that's important because, as I mentioned earlier, so many patients remain undiagnosed. So the patients are given out this form, and they rate, and there's 8 categories that they rank different activities that accommodate on a scale of 0 to 3. If you score a 10 or greater, it'll indicate that you have a possible sleep disorder and that you may want to refer them for additional testing. Additionally, you might see, if you're working with a sleep study physician, you might find this scale on sleep reports. So it's good to be familiar with it. There's 2 main ways we test for obstructive sleep apnea. One's a sleep center study, and one's an at-home sleep test. Polysomnography is the type of testing that we do at a sleep center. And it has a lot of benefits because it gives a lot of information because it has all these electrodes connected to the patient. So it'll tell us information about heart activity, brain activity, eye movement, muscle movement. There's also an audio feed, so that's necessary if you want to diagnose nocturnal bruxism. It has a visual feed as well. The drawbacks are that since there are all these connections, some patients might have trouble falling asleep with all these wires on them. Also, some people just might have a hard time sleeping not in their own bed or away from their own home. Also, it's more expensive, and it of course requires some scheduling. The polysomnography is still definitely the preferred testing method, especially if they have other health problems, but another option is an at-home sleep test or an HST. The benefits are that it's easier, it's cheaper, it's less intrusive, and of course you can do it from home. There's a couple of types of this test, but generally it consists of a nasal cannula that'll detect airflow, a chest strap for measuring heart rate, and a pulse oximeter for testing blood oxygen. The drawbacks are it can be less accurate. Some of the inaccuracies stem from the fact that the patient's putting this on themselves, and there might be some user error. And the inaccuracies tend to be on the side of a higher number of false negatives. The reasoning behind this is that this test does not show whether you're awake or asleep. So it's possible that you'll come up negative for sleep apnea, but the reason you're not having these apneas is because you were never asleep in the first place and you're awake. So of course you're not going to have an apneic episode. As I said earlier, the preferred treatment for severe sleep apnea is a CPAP machine, where you have a mask over the nose that acts as a pneumatic splint to allow air to flow through. It's very effective, close to 90%, but unfortunately it has a pretty poor rate of compliance. Part of that is that not everyone can tolerate a CPAP machine. Sometimes it's as simple as trying a different type of CPAP, but other patients may not be able to tolerate it at all. So those are some of the patients that we can help as dentists. There's a lot of dental appliances that could be helpful, but Kathy and Valentina are going to speak more about that in a few minutes. There's also a lot of ortho and surgical options that I'm not going to speak about today, but doctors Taliwal, Shupak, and Gleed could speak about that at another time. In summary, it's not in the scope of dentistry to diagnose sleep apnea, but we certainly can screen and train patients for it. That's really important because there's so many people in the population that suffer from sleep disordered breathing that aren't diagnosed. And as I said earlier, a lot of these things like heart disease, stroke, mood disorders, a lot of times it's easier to just treat it with a pill than to treat the underlying disorder. And since it's so prevalent, people just start to think of it as normal when a lot of it really could be prevented. Also, a lot of the people who are diagnosed, they might have failed or been unsuccessful with previous treatments. And if that's the case, we could step in as dentists and really have a positive impact to increase their lifespan and improve their quality of life. So I hope I've helped you understand the value of treatment. And I think it's important for us to be able to share this with our patients so they could perceive how important it is and move ahead with diagnosis and of course, comply with treatment and improve their lives. Thank you.
Thank you, Ilana. So I wanted to say a few things.
Can you please mute yourself?
Sure.
So Ilana, thank you very much. I just want to say a few things about this morning's presentation, which I probably should have said at the beginning. What I said was that we got together and we came with a concept of how to present this very massive field of airway dentistry. And between Gail Shupak, Rita Taliwa, Alan Gleed, David Weinstein, Valentina Lisova, and Cliff Melnick, we realized that this is very, very massive. And how do we come in and talk about it in individual groups like this? There are actual residencies about this. And for example, our last speaker, Kathy Cohen, has done a course of training in that, and she's a diplomate of dental sleep medicine. So the best way we were able to present it to you is we take it, and I'm going to use myself as an example because I didn't know a lot about this, is that I didn't even know what I didn't know. This is people that know me see that I use that expression a lot. And the whole idea behind this series of groups is that talks is that to take you from you didn't know that you didn't know to now you know that you don't know. And then we are going to provide as much resources as we can for self-study, because it's definitely beyond the scope of 5 or 10 CE credits. Spear Study Club, on their website, they have some excellent videos that you can watch, and it talks about diagnosis. There are videos that they talk about how to make the appliances, various appliances, and all of them are beyond the scope of this. So after today's presentation being the concluding in the series, if you're interested, please reach out to us. You can go on their website and watch these things. Spear also has made it available to people during pandemic that they can give you a free pass to go and try these things out. So don't be shy to reach out and say, hey, I feel that you're just touching the surface here. I want to learn more about it, and then we'll give you the resources to study it on your own, and they're very easy to follow. Ilana, thank you for the brief overview of it. What she was trying to do is basically give us the vocabulary that we needed in order to communicate with the physicians, because for a dentist to be able to deliver sleep dentistry appliance, he or she will basically act the way a physical therapist act in relation to a physician. The physician makes the diagnosis, and then they send them out for a particular therapeutic. And in this case, for dealing with sleep apnea, then we'll be delivering the therapeutic based on the diagnosis that comes from the physician. Valentina is next. I'm going to pass the microphone to Valentina, and Valentina is going to continue the conversation from this point on.
Nima, can you hear me now?
Yes, we can.
Okay. So just want to kind of repeat what you just said in terms of we as dentists are not allowed, or we can't diagnose the sleep apnea. So in order for us to fabricate the appliance, it has to be prescribed by a physician. So there are two ways how the patient can get to us. First is that he or she goes to see a physician with certain complaints, and a physician prescribes a lab study, sleep study, and then based on the results of that sleep study, they might get either a CPAP or an oral appliance prescribed. And then the patient comes to us with their sleep study results. Or the other way, you can look in the patient's mouth, or you can talk to the patient and they would complain about their sleepiness during the day. You would see some signs and symptoms that Ilana just described. And you say, well, why don't you go see a physician and get a sleep study? And again, patient comes back with a sleep study result, and we should be able to look at the result and have an idea what it is about, even though we know we need to fabricate that oral appliance. And Dr. Cohen is actually going to present one of the sleep studies, one of her patients. It's an actual sleep study. And she will describe it and explain what we need to look for and what the numbers actually mean. And here we go. So Dr. Cohen, Nima, do you want to present Dr. Cohen?
Sure. So Kathy Cohen is a good friend of mine. We were classmates back at Stony Brook. And I know a few Stony Brook graduates are in the group right now. Kathy has actually practices in New Jersey. She is part of Sleep Dynamics. I think she is part owner at Sleep Dynamics, which is one of the accredited sleep study centers by the Academy of Sleep Medicine, or Dental Sleep Medicine. She will tell us more about that. She has her diploma in that. She was practicing general dentistry for a while. She went, she's graduated from Stony Brook, went for her GP at Maimonides Hospital, and then in the last year or two, she has gone back for additional training, and she got her diploma in sleep dental medicine, and has been focusing her practice mostly on sleep dentistry. One of the more knowledgeable people that I know, and she was kind enough to volunteer her time for us today.
Hello. Can you put the
Ida?
sleep study?
Yeah, sleep study.
Kathy, I'm sorry to interject. You need to unmute yourself and start over.
Can you hear me now?
Very well. Go ahead.
Thank you. Okay, this is 21 a sleep study of 21-year-old male, and he is on the heavy side. His BMI is 33, and this is actually a prime candidate for the obstructive sleep apnea problems. And usually we assume that obstructive sleep apnea is a disease of the older generation, but with obesity is so prevalent in America. More than 70% of American population is afflicted with problem with weight, and a lot of people have obstructive sleep apnea not knowing about it. And this young man actually has a borderline apnea, obstructive sleep apnea. Usually as Ilana said previously, mild sleep apnea, it's from apnea-hypopnea index of 5 and it borderlines 15. But he has 15.5, so he's in a borderline between mild case and moderate. And he, as we see, it's a summary, it's a first page of the sleep study. And in impression, it's indicated that he has mild sleep disordered breathing, which is actually like what borderlines moderate. And he has he's a loud snorer, and he has significant oxygen desaturation. So when you see the paragraph in the summary, you can see at the end, the last sentence, it says that his oxygen desaturation dips down to 83%, which is quite low. And also, I want to tell you what apnea-hypopnea index mean, so you can understand better. What it means in his case, that during his sleep study, he would stop breathing. He would stop breathing, or his breathing reduced to 20% of normal breathing activity. And he did it approximately 15.5 times an hour. So it's quite significant if you think about it. So every 4 seconds, he would have the episode of reduced breathing. So, and he had very low oxygenation level. Second page, you can see that it's, can you switch it to second page, please? Valia, Valentina? Nima?
Yes, we're here.
Can you switch to a second page, please? Page 2.
Just a moment.
Thank you. I'm going to continue talking about the case and discuss it more. So that male was presented with an option of CPAP machine, which is quite big and loud and cumbersome, and he decided to he's not going to use CPAP under any circumstances. Well, that's what he told me, and he decided to obtain an oral appliance. And when he came to the office, also he complained that he did not have a restful sleep, and he had actually it was very difficult for him to wake up in the morning. And he actually noticed that he would doze off to sleep quite easily, and that actually what younger people tell me. They actually do notice. Older people on average, they're not that aware that they have trouble of staying asleep. They feel that they are perfect. They don't see that anything going on with them, except they complain of tiredness. And this is important to note. Also, younger people, their prime concern always is snoring. And a lot of times they don't even care much unless you really work with them and explain them that about the problems associated with sleep apnea. They their prime concern usually how they come because of snoring problem, and that's really prevalent. And if they see that the snoring issue is resolved, they actually very grateful and happy, and that's a very good indicator for them. It's very visual for them, so it actually makes them to be more compliant. That's why oral appliance is so well received by the patients compared to CPAP machine. Actually, as um, you noted before that the people, the population, the patients are compliant 50%, compliance 50% with CPAP machine, but in reality, it's after 1 year. In the long run, after approximately 5 years, compliance is approximately between 45 and 30%. So it's very hard to stick to the CPAP machine and use it every night. Not many people see benefit of that machine right away. Even if they do see it, they claim that it actually bothers them to sleep. They have serious burn marks from the machine, because the nose piece and mouthpiece has to be attached to your body to your face with a special belts, and those belts and moisture creates irritations on your body, and it's very visible, and the people really don't appreciate that at all. And also, when a lot of complaints I see that patients, when they turn side to side, the CPAP mouthpiece comes loose, and the air blows very hard in the ear, and they have a lot of problems with the ear too with time. They really do not like to use the machine because of that. Is it possible to switch to page 2? It's kind of stuck.
Dr. Cohen, which page are you seeing in your screen?
It's page 1.
We are actually on page 2 right now.
Yes, so it's for everyone else, it's should be showing the page 2
with a table and a grid.
Yeah. Let me go over then. Yeah, I don't know. Okay, so if you see the first table of the page number 2, you can see it's called respiratory event summary, and it goes over obstructive apnea. OA stands for obstructive apnea, and then A plus H events. It's how many apnea, hypopnea events happen during the sleep, and rarer, it's respiratory effort-related arousals. What it means that how many times person was awakened because of he couldn't sleep, because of he couldn't breathe, and rare events, actually, it's not only like a 1 second. It has to be at least 10 seconds or more to register. And underneath, you can see apnea, hypopnea index, and total sleep time. And the total sleep time, TST, it stands for total sleep time. It's average apneas and hypopneas in events which occurred. And NREM, it's how many apneas occurred in non-REM sleep, not deep sleep. And REM, how many apnea, hypopnea events occurred in REM sleep, when actually person gets paralysis and his muscles or her muscles completely relax and he cannot move. And usually during the most heightened amount of apneic and hypopneic events, we observe in REM sleep on average. But in this case, it's a quite even number. And underneath, you can see third table, and it says body position data. During the sleep study, it's recorded what position person has apneic and hypopneic events. And in that case, they note the time person spends in the on the up position, supine position, left and prone and right side, and then it's noted in the last paragraph that RDI stands for respiratory disturbance index. And what the respiratory disturbance index stands for, they actually add apneic, hypopneic events and rare events. Rare events, it's when, as we said, it's respiratory effort related arousals, how many times person had to be waking up because of deficiency of oxygen. And then can you switch to the page, last page? Oh, actually the page number 4, the oximetry distribution. Hello, can you hear me?
Yes, I think the screen is not rendering on your.
Yeah, it's frozen. Yeah.
That's okay. So we are on the last page, right, Ida?
Yes, this is now the page number 4.
Where the graph is with.
Not very last page, by the page where the it has oximetry distribution chart. Do you see it? It's one before the last one.
Page number 3. I have it
Ida,
open.
you're mute.
Mm-hmm.
We're catching up, guys.
So it's now
That's
on the
the correct
page number
yeah.
3, which
Yeah,
has
that's
the
the page.
oximetry distribution. Okay.
Kathy, we're ready.
Mm-hmm. So I'm trying to adjust it. Okay, great. I caught up. Wonderful. So oximetry distribution, you actually have to know only one important detail on that page. And if you see, it says that less than 90 and then minus minutes. What it means, it's less than 90%. And it's less than 90% of oxygen saturation. And that's what you have to observe if person has approximately more than 3-5% of oxygen desaturation during the sleep during the night. That's a warning sign. You have to really see and treat that patient. And then the last page, it's a graph, and it shows you, yeah, perfect. It shows you what happened at the end. It shows you the position. You see, like, if position of the patient, very bottom, and the hours. The sleep study started at 10 o'clock and finished at 5. And above its microphone, its mic, it shows the snoring, and it's quite significant. You can see vertical lines in green. That's significant snoring the patient endures. On the very top, it's saturation of oxygen, and you can see how it dips down. You can see the points from 70 to 100%. And the heartbeat above that. Below that, it's OA. It's obstructive apnea episode, and you can see it in red vertical marks. And you can actually count them. And then hypopneic event, it's in pink, and it's like much more often occurring. You see hypopnea in pink. And then it's also goes goes about the stages. It's from wake, W, to below N3, deep sleep, and R stands for REM sleep, and it's in red. You can see it. And if you see below, actually hypopneic event, a lot of hypopneic event happens in a red portion, which is in REM sleep. You can see like red portion of the sleep event, REM, and right above hypopneic lines in pink. Do you see it? Okay.
I think we're all on. Yes, go ahead.
Yeah, that's how you know MA. It's muscles. What muscles movement happen? What kind of muscles movement happen? I see. Okay. Muscle activity, it stands for. What happens very often, a lot of people also have restless leg syndrome or repetitive leg syndrome, where at night, actually restless leg syndrome even more, when they feel like they cannot fall asleep because of constant urge to move their legs or extremity. Usually it's legs, and they feel like pins and needles, and as soon as they feel it, they have to kind of move and wake up, and they are restless, but it's not an obstructive apnea problem. It's another problem which connected to the actually ferrin level, with problem with and serotonin level. It's another issue. A lot of actually women have it a lot, and the treatment for that, they have to go through it, check their blood, and not only that is a cause of restless leg syndrome. It's very hard to actually to treat that issue, but that's how they will understand how a person moves during the sleep. Is it clear? And you can see it on MI graph. It's right below OA, obstructive apnea. Okay, let's, Nima tells me that I have to wrap up soon. Okay, let's, we have to show how I actually work and what we use. There is an appliance, armamentarium of appliances we use, and Valentina will go over it.
Done? Okay. Okay, great. Thank you very much, Katie. So the next piece of our presentation is going to be on sleep bruxism. Basically, we have decided to include it because there's been a lot of interest in the relationship between sleep apnea and sleep bruxism. Some clinicians are actually advocating the assessment of sleep bruxers for possible underlying sleep disorders. And also, even in patients with temporomandibular disorders that are possibly caused by sleep bruxism, there might be an underlying sleep apnea that we need to be able to recognize, and these patients need to be treated differently. Another point that I wanted just to mention before we go into a presentation about sleep bruxism is that sleep bruxism is defined as a disorder characterized by rhythmic masticatory muscle movement activity and occasional grinding and some clenching. And the gold standard to actually diagnose sleep bruxism is a sleep study. Now, the next presentation is going to be from SPEAR. It's a SPEAR presentation by Dr. Kevin Cushion. And what I wanted to say is that he's going to talk about how actually us making some occlusal or occlusal guards or night guards in patients with sleep apnea can hurt them. And we were discussing that with Dr. Cathy, Dr. Kwon yesterday, that in patients with sleep apnea, occlusal guards are actually contraindicated. So now, Ida, if you could just please start the presentation.
Well, welcome to Lesson 2 of this course on dental occlusion and airway. And in Lesson 2, what I want to do is we're going to talk about promoting and maintaining health with the proper appliance. Now, what do I mean by that? Well, I'm going to tell you a story. I'm going to tell you a story that started with me in about 2008 through the beginning of 2009. I had 2 patients, both within the age of 25 to 30, so basically young adults. One was a male, one was a female. Both we confirmed that there were some parafunctional habits going on. And upon the exam, they both had moderate tenderness of their temporalis and their pterygoids. Their joints were within normal limits, but both were aware of changes of their front teeth starting to break down. So on the left is Michelle, your left is Michelle, the female, and you can see some wear along her edges and some thinning of the enamel. And on the right is Jeff, and with Jeff you can see basically his teeth are starting to get very flat and his lateral's a little bit worn and they're really starting to break down and basically all the way to the dentin. So what do we do for these patients? Well, they need a splint, right? They need something to protect their teeth. So I was always doing splints at this point in a fully seated collar position or centric relation. Both of these appliances were, if I may say so, they were very well adjusted over multiple appointments. So I really trusted that it was a fully seated collar position, that it was really a true physiologic occlusion. But I was seeing some things that confused me a bit, and I'm going to go into more detail about that in just a minute. But I saw some things that were confusing me a bit with both of these patients. And what I want you to know is I saw them with these 2 patients, and there may have been several more too, but I'm going to use these 2 patients as an example. So I thought, what is it about this CR thing? Maybe I should take a step back and make sure that I should be doing these splints in a fully seated collar position. So, trying to be the academia person that I was back then in 08-09, I thought I'd do a lit review. And luckily there was this nice article in 2009, Comparative Evaluation of the Efficacy of Occlusal Splints Fabricated in Centric Relation or Maximum Intercuspation in TMD patients. Perfect. Well, in this article, it actually said that 2 patients, and there was 2 groups of patients, I won't go over the whole study with you, but 2 patients in a certain group did not achieve occlusal stability. And these findings could be explained in 2 reasons. I thought, well, sweet, I got 2 patients right here also, so let's look into that a little bit. And what the journal article said was the first would be related to the normal variation in the arc of closure, and that it depends on the physical status of the muscles, which may be influenced by physical and mental distress. Well, in other words, maybe there's other things going on in the body creating physical or mental distress. I'm like, okay, that makes sense to me. And the other is that if in fact we come in, we're doing our exam, we redo our exam with the muscle palpation, and the muscle palpation wasn't completely reduced yet. So I'm thinking, okay, well that makes sense. So basically what that says to me, and it said in the article as well, is that the difference between CR and MI should be considered. And when there are large differences between these positions, the use of CR may be more favorable. Made me feel pretty good, right? So I liked what I was doing. So here are the two patients. You can see Michelle on your left and Jeff on your right with their appliances down and through there. And so why did I start this journey of looking through the lit review? What were the things that made me wonder? What was going on that I didn't like about their appliances? Well, again, I mentioned that I had adjusted these appliances multiple times. What I was seeing was they would come back in 2 or 3 weeks and there were still notches in these appliances, and their teeth weren't really sharp, right? They hadn't worn their teeth to sharpness. They were creating notches. If you look at Michelle's on the left, you can see these deep grooves that she'd created in just a couple of weeks with not sharp teeth, I want to remind you. And what happens when now she wears through that, because that's her immediate posterior disclusion, right? That's the protection of her back teeth. Well, then she starts to pick up an interference, as you can see here, on the molar in the back. Well, now what that means is that our temporalis and our masseter starts firing because those muscles fire when back teeth touch, which now makes everything worse. So now she's really just grinding it. And you can see Jeff's over here on the right, same thing, some deep, deep grooves he's wearing within 2 to 3 weeks. In the cuspid area, and same thing, as he starts to wear those down, his teeth aren't discluding as quickly, right? It's not immediate posterior disclusion, and so you start to see these dots in the middle where basically as he starts to get out of the fossas, he's got an interference, and same thing, the muscles pick up, and so now he's really beating that up even more. So I'm thinking, well, why are they grinding through to that place? Why are they beating up my cuspid rise or my posterior protection in the first place? I created physiologic occlusion for them, right? And you can see their teeth here. They are not sharp, really beautiful teeth. Interestingly, though, one thing I want to point out is Michelle's teeth, which are on the left. I want you to see her mandibular first molar on the right. It's got a crown on it. I did the crown. Why did I do the crown? Neither of these patients had any restorations, and neither did that one. That one had cracked mesial to distal, and I put a crown on it to protect it. So I just thought, wow, she's really beating her teeth up, right? You're starting to get where the story's going. So I thought, I really need to shut these muscles down, right? Well, maybe an NTI, or as we teach here at Spear, what I've been using is an anterior bite plane. So I did a lit review on that. I thought, okay, and then actually I did an anterior bite plane as well because I wanted to shut them down. Well, there's a nice article in about 2007 that said, several studies have examined the EMG activity of the masseter muscles in response to occlusal splint treatment. And what we found is some seem to increase and others decrease the EMG activity. I'm like, what? How could that be? I thought it was supposed to decrease it, right? Well, as we move on, it says, the same article says, well, the proposed mechanism is to reduce the muscle tension. But a recent study was unable to demonstrate a significant difference between the NTI and a conventional oral splint in treatment efficacy. So here I'm done both, and the neat thing is, scary, but neat, this is exactly what I was experiencing. What's in the literature is what I was experiencing. No matter what I put in their mouths, they're beating through it. Even if I try and take the muscles out of play by doing an anterior bite plane, they're still grinding through it. So you can see here the notches that are in that anterior bite plane this was really within probably a week to 10 days. So again, that study says the possible pain or discomfort relieving effect of an NTI or occlusal splint has been demonstrated in some, but not all studies, and it suggests a possible involvement of other mechanisms. Well, now it had my curiosity, because now I'm saying, man, this is exactly what I saw. What are these other mechanisms? So I thought, I'm going to take a step back, because they're doing it at nighttime, because that's when they're wearing their appliances, right? I'm going to go back, and I'm going to be the smart guy that I'm trying to be, and I'm going to revisit bruxism. Well, there had been a nice article done in 2008. Remember, this is sort of into 2009. Bruxism, Physiology, and Pathology, an overview for clinicians. Perfect. Exactly what I'm looking for. And it says that sleep bruxism is a sleep-related movement disorder. Okay, well, that's why we call it sleep bruxism. That is secondary to sleep-related microarousals. And hereditary or genetic factors of the upper airway resistance in the genesis of this rhythmic masseter muscle activity and of sleep bruxism are under investigation. Ooh, now that one got me going too. And the other thing that got my attention is that it peaks in the minutes before rapid eye movement sleep or REM sleep, which suggests that some mechanism related to sleep stage transitions exerts an influence. I'm thinking, sleep? Come on, they're just grinding their teeth at nighttime. Now we have to start talking about sleep stage transitions being part of sleep bruxism. Well, so I went on. I actually did a search for bruxism and sleep, bruxism and breathing, and bruxism and this apnea thing. And there had been an article back in 2004. I'm thinking, where was this? But back in 2004, there was an article that the title was Aggravation of Respiratory Disturbances by the Use of an Occlusal Splint in Apneic Patients. It was a pilot study. Well, it said that this open study suggested that the use of an occlusal splint, that's what I was making, is associated with the risk of aggravation of respiratory disturbances. It may therefore be relevant for clinicians to question patients about snoring and sleep apnea when recommending an occlusal splint. I'm just going to do an occlusal splint. I have to start questioning my patients? Well, this could not be my patients, right? I'm thinking I can question patients, but these are not my patients because they're not apneic. They don't fit the profile, right? So I looked a little bit more into it. This was an 2009 article, Clinical and Societal Consequences of Obstructive Sleep Apnea and Excessive Daytime Sleepiness. Well, look at the risk factors. Obesity, nope, you can look at their photos, neither of them are obese. Large neck circumference, neither were greater than 42 centimeters. Hypertension, nope, neither had hypertension, at least not consistent. Other factors included craniofacial abnormalities, nope. Variation in pharyngeal structures, I can't check that for sure. The use of sedative drugs, nope. Smoking, neither, and alcohol, neither, except social drinking on the weekends. So, right, they don't fit the profile. But then the study continued, and it said that a number of the conditions are comorbid with obstructive sleep apnea, including depression, and that it's likely to contribute to management of the comorbid conditions and their clinical consequences that obstructive sleep apnea is. In fact, it said it might include memory loss, distractibility, irritability, deficits in alertness, perception, and concentration. Well, this grabbed my attention because as I'm trying to figure this out with both of these patients, actually, we'd had conversations about both of them feeling sort of depressed, both of them struggling with focusing at work, both of them struggling with memory, and they thought they were too young for it. And I remembered them saying that. Well, now this got my attention. And so what I did is I wanted to look deep into it. And maybe you started to see a name already, which is Guy Levine, or Giles Levine. You can say it how you want to say it, but he still is very prominent in my learning today. And what I did in 2009 when this book came out is I bought this book. And it was the first book I read. So I want you to start to notice his name on some of the studies. And I also want to throw out that this was the first book I read. I decided if I'm going to learn about it, I'm going to get this book. So as you start to see his name, and on this study, back to the pilot study back from 2004, what I want you to see is that this study said that 4 patients experienced an aggravation apnea diagnosis category on the night they used the splint. So they used an occlusal splint, and things got worse. Well, actually, I'm going to come to Michelle now. So Michelle actually went and had a sleep study that we're going to go into in a little bit. And on her sleep study, she was diagnosed with obstructive sleep apnea and upper airway resistance syndrome, and periodic limb movement was possible as well. Well, now you've got my attention. That same study, in a few minutes we're going to talk about some terminology, but in that same study it said that the AHI, which just I want you to know that's bad, was increased by more than 50% in 5 of the 10 patients. The RDI, which is also bad, showed a 30% increase from baseline to splint nights. The percentage of sleeping time with snoring also increased by 40% with the splint. So in other words, when patients were wearing an occlusal splint, all of those things got worse by quite a bit. And now we look at Jeff. And I look at Jeff, and I look at his appliance, and I look at his tired eyes, and I look at the bags under his eyes, and then I look at that splint, and I see the marks on it, and I picture him in the middle of the night, and I see him just struggling, just beating himself up, and he's exhausted. And I see it differently at this point. I see that when he's wearing this appliance, he's everything I just talked about. All those numbers I talked about, he's worse. Well, that same study, it suggested that the use of an occlusal splint is associated with the risk of aggravation of respiratory disturbances. It may therefore be relevant for clinicians to question patients, right, about snoring and sleep apnea when recommending an occlusal splint. Well, how do we do that? Well, we're going to go into this a little more later, but we can start using the Epworth Sleepiness Scale. If all we do is just ask our patients, you can use the Epworth Sleepiness Scale. Another one that works really well is a bed partner survey. And again, we're going to go into this in a little more detail later, but a bed partner survey, because you know what? If you fill out your own history on if you're snoring or not, you might not be so honest. You give it to your bed partner, and they're going to answer some other questions, including the Epworth, and you might get some different answers. Another thing you can help patients, because remember, now we have to question our patients, that's what the study said, is you can use the stop bang, which is really good as well. So S is snoring or snoring loudly, T, are you tired, O, has it been observed that you stop breathing, and P, do you have high blood pressure? You can move on to the bang, which is body mass index more than 35 kilograms per meter squared. Are you older than 50 years old? Age, is your neck circumference greater than 40 centimeters? And are you male? So here's the issue. If you get 3 of those, you're a high risk for apnea. Well, if you are an overweight male over 50, sadly, you're already at high risk for apnea because you've already got 3 of those things. So fine, I'll question my patients, but they still don't quite fit the stereotype of all that, right? I get it, and I'm worried about them, and I see that could be happening, but I'm still questioning because they don't fit the stereotype. So I did a little more research. And here's an article that is prospective randomized study of patients with insomnia and mild sleep disordered breathing, done in 2008. Well, same thing. It said that a lot of these patients in this study actually did not fit the profile. So many of these patients with mild sleep disordered breathing didn't fit the typical profile. Okay, fine. Maybe they're apneic. But what about the bruxism, though? I get that they're apneic, but they're grinding through the splint. What about the bruxism? So I kept going on, and there's a study that was done in 2006 that compared the maxillary occlusal splint and active mandibular advancement appliances or devices with the advancement. It also revealed a significant reduction in sleep bruxism motor activity. I'm going, no way. Tell me more about it. Well, another study that was actually even more recent back in the time, it was 2009. It was the effect of an adjustable mandibular advancement appliance on sleep bruxism. And it was a sleep lab study. This is a great study. And it said that the mean number of sleep bruxism episodes per hour was reduced by 39% all the way to 47% from baseline with the mandibular advancement appliance at protrusion of 25 and 75% respectively. Let's break that down. Basically, if the mandible was about 75% of maximum protrusion in this study, the bruxism went down almost by half, 47%. Ooh, now that's got my attention. Well, I want to tell you the rest of the story, actually, because we talked about Michelle, who went and had a sleep study, and yes, she was apneic. And Jeff, actually, although he was in between jobs, so he couldn't go have an in-house sleep study, which we'll talk about in a couple minutes, but he did have an ambulatory sleep study because I wanted him, now I'm into this, I want to get it figured out, I'm going to do whatever I can for him. Well, even with the ambulatory sleep study, his findings were consistent with positional obstructive sleep apnea, and it even said that a mandibular advancement splint will likely provide treatment benefit independent of OSA severity. Well, they were actually brother and sister. Remember the hereditary component? Man, it's all coming together. The literature is true. And here is their dad. Here's Tim. Why am I showing you Tim? Because I met Tim in about 2003, so 5 years before everything I've been telling you so far. And here was Tim. Here was one of his photos. Here was his photo back when I was just trying to implement photography into my practice. It's a terrible photograph, but the neat thing is, and by the way, even with terrible photographs, look what you can see. Look at the wear of his teeth. Look at how one cuspid is long and the other cuspid is short. Look at how the laterals are worn. Look at the difference of free gingival margins. Look at his uneven plane of occlusion. Look at everything we talked about in that exam. And so what did I do because he was beating his teeth up and he had just moved, so he was really in transition, so all we want to do was protect his teeth, right? What did I make him? What had he been wearing for 5 years? A pretty well-adjusted occlusal splint that he was grinding through. So he went and had a sleep study. He was diagnosed with obstructive sleep apnea, severe, periodic limb movement disorder, and here's what I want to share with you, and we're going to dive deep into this in just a couple of minutes. he had 75 microarousals per hour of sleep on average. His AHI, which again is bad, basically something bad was happening about 70 times per hour of sleep. And something bad was happening with his breathing, and a different indicator, 74 times per hour of sleep. And he actually, his maximum duration, which means the longest time he stopped breathing during the night, was 92 seconds. And his oxygen levels dropped down all the way to 66%. 5 years he'd been suffocating. So my lesson was learned. They were a family, a loving family, all came together with the three of them, and there were so many more patients in my practice. Maybe I really was suffocating my patients. So I thought, if I'm going to continue to treat patients, and I am, because I want to treat these patients with occlusal disease whose teeth are breaking down. I want to help them get better, but I need to know more, and it's going to have to start with sleep. So in the next lesson, we're going to talk a little bit more about sleep. I hope that this second lesson helped you sort of see the dilemma that a lot of us have had, that a lot of us are having, and I think we're going to continue to have. We want to protect people's teeth, and we want to use physiologic occlusion. We want the joints in the right spot. We want the teeth touching evenly and simultaneously. We want them to slide freely. We're doing everything that we think is in our patient's best interest, but we might be suffocating them too. So let's talk about sleep in the next lesson. I hope this lesson was good for you, and I'll see you in the next lesson.
Okay, thank you, Ida. Before we go into discussion of sleep appliances, I just wanted to make a couple of points. So currently in the literature, there is still no clear relationship between sleep bruxism and sleep apnea. We did send you an article. That's the name of it is The Link Between Sleep Bruxism, Sleep Breathing Disorders, and Temporomandibular Disorders. It has a lot of interesting points. Again, it's been suggested there is a relationship, but it's not clear what type of relation, what triggers what comes first, what comes second. I think it's also interesting is that what both sleep bruxism and sleep apnea have in common is the muscle activity or tone. So when the patient bruxes, their masseter muscles fire, and they have increase in tone, and that actually allows genioglossus muscle to dilate the upper airway more efficiently. And basically, in other words, bruxism is a protective mechanism in patients with sleep apnea. I thought it was an interesting point to make. And there is actually in that article, there are a lot of these little details that they discuss GERD and sleep bruxism and how bruxism actually is a protective mechanism. Now, again, if you would like to watch some of the videos, Ida will send you a link. There is more of it, and we just unfortunately don't have enough time. So the third part of our presentation is again by Dr. Cohen, Kathy, and we're going to talk about the appliances. There are actually about more than, I don't know how many, but around 90 FDA approved appliances. They're all different. Not all of them are actually good appliances and should be used, but they're out there. We are going to present two appliances. One appliance is a Herbst appliance that's presented by, again, from a Spear online course. And the second appliance called Oasis appliances, that's what Dr. Cohen uses in her practice, and she finds it the most useful. She'll talk all about it. And then also we're going to talk about how to titrate these patients. Basically, how do you record the position in for mandibular advancement appliance where the patients are going to feel comfortable, and we're not going to cure their obstructive sleep apnea, but we're definitely going to improve their breathing. Now, how we define the success? What's actually going to tell us, yes, the patient is much better, and we should continue with their therapy. So now, Ida, if you could just please turn on that Spear presentation by Dr. Steve Carstensen regarding Herbst appliance.
Herbst is a long-standing appliance It's been used in orthodontics for a long time to help influence growth for class 2 patients in young years. This was one of the first well-qualified oral appliances for therapy, and it's still a very, very viable appliance today. What we have here is custom-made trays for top and bottom. You can get those made out of a number of different materials, including some nice rigid plastics. And then the framework along the side there is a telescope. So it's attached to the back of the top and the front of the bottom. Remember the conversation just about Emma's, it was opposite to Emma. And so as you open your jaw on the herps, your jaw can continue to fall backwards. That means that most effective herps are the ones where the patient is contacting top and bottom together. And as you see on the screen there, there's a little ball piece right here on top and bottom, and they put an elastic between top and bottom that influences their jaw to stay closed. So a herps, you have to put rubber bands on. That increases the patient's complexity and need for compliance. That's a negative for a herps. But you can also advance that mandible quite a ways with a herps, and then you can even advance it further if they need to. So it's very adjustable for patients to move on. This is also an appliance that's quite handy for the patients who say, you know, I can't stand the thought of having my jaws tied together where I can't open my mouth. Because on a herps you can. If they don't use the rubber bands, they can open freely. If they use the rubber bands, they can open a little bit, just like kids do with orthodontic elastics. There's also very little in the tongue space on a herps. So you have one of your patients with a narrow arch. There's not a lot of space for the tongue anyway. You want to avoid having more things in between the arch form of the teeth. A herps is an excellent device for on the sides. Quite rugged, and it withstands quite a bit of bruxism. So if you have a patient who has ground down their teeth quite a bit, and the big heavy masters, you think they're going to continue that activity, herps is a good one to do. Very easy to adjust the vertical on a herps too, because you just simply add acrylic to the lower arch form, and so you can build up the vertical on a herps. It's a very, very popular and common appliance.
Okay, thank you, Ida. And now can you switch to the presentation, please?
Yes, give me just a
Showing the-
moment.
Sure. Casey, while Ida is working on it, can you please answer one of the questions that I just received? I sent it to you.
Dr. Lisova, is this what you were looking for to see?
Hello?
Kathy, you're on. Go ahead.
Yes. Okay, this is an Oasis appliance. I actually like to use it with younger patients and with a lot of patients actually, because it doesn't have a connection between the upper and lower jaw. Although Medicare demands us to connect upper and a lower jaw together with the hinge appliances, it's by it's indicated to use to be used. We can't use, unfortunately, that kind of Oasis appliance with Medicare patients. But I found this one Oasis appliance is very comfortable and very easy to use. So the top portion, it's a clear retainer. It's like a Invisalign retainer. A patient places on the top of his teeth, and then he places the bottom portion, blue portion, and that on the top you see it's called nasal pillars. what you can do with them, if you actually bend them out of your mouth, you spread your nostrils and you can breathe easier. It does not improve your OHA. It does not make any difference, but what it does, it creates comfort. So patients can sleep easier and breathe easier during the sleep. And on the bottom of the appliance, blue appliance, you can see blue buttons. It's actually for exercise of the tongue, which is there is a study about it, and it's claimed that it helps. I don't know. I am dubious about it at this point. So, and I don't use those buttons because I believe it's extra material in patient's mouth, and not everybody appreciates that. And if you can see on a side, that's a mechanism. Actually, I actually have this appliance with me, so I can show you mechanism how you. So that's an appliance. This portion goes on the bottom, on a mandibular teeth, and that portion goes on the top. And adjusting this portion, you can protrude lower jaw forward. How it looks like. So you insert, there is a adjustment mechanism right here. Can you see it?
Yes, we can.
Yes.
You open it up from both sides. And you push the side portion of the appliances inside, and that's how the lower jaw is protruded. And it's comfortable appliance because there is nothing, not very minimal material in the lingual portion of the mouth, and very minimal material on the side. It's like very comfortable to use appliance, and patients usually favor that. And the nasal pillars, you adjust like that, and during particular the allergy times like right now, patients can breathe easier by spreading their nose like that. That's what it does internally, intraorally. And what I usually, how I usually do it, with a George gauge, I record what is the maximum protrusion on the patient. And on average patient can protrude 10 millimeters. And when I set my bite for the appliance to begin titration, I usually start with 50%. So I protrude lower jaw 5 millimeters. And that's an optimal position. And usually it does work very well. If not, you can protrude more. And every time you see patient, you advance mandible by 1 millimeter. And until you see that patient says, yeah, I stopped snoring, I feel better. And then at that point, you can send patient, usually it takes around between 1 month and 3 months to evaluate and create a best titration parameters for the patient. And after you created a most comfortable and easiest to breathe position, you send a patient to PSG study, to study in a lab. At that point in the lab, what happens when patient goes to sleep? The recording, they record their apnea hypopnea episodes, And if the technician, sleep technician, sees and observes that patients still have some problems and still have a lot of apnea, hypopnea episodes, what they do, they wake up patient and advance mandible further by 1 millimeter. And they can do it approximately twice during the night and improve reading in that matter. And if they see it's a much better, better result, a patient comes back with a sleep study, and after that you can adjust your appliance by the measurement technician observed. So if it works the best when the sleep technician adjusted by 1 millimeter, you adjusted by 1 millimeter further. If by 2, you adjusted 2 millimeter further. And it's been very effective. In regard of Herbst appliance, it's a very good, very sturdy appliance. It's excellent. It works very well. It's a little bit claustrophobic for a lot of patients because it does connect to parts of the patient's mouth together, and it's harder to move your jaw with that. So if people are trying to they feel a little bit more immobile with that, but it's usually well tolerated by all the patients as well. And also the same principle. On the side there is a hinge, and what you advance hinge slowly. Every time the patient comes, I start with 50% of advancement, and I protrude the advanced jaw 1 millimeter at a time until the patient sees improvement. I send him to the lab to prove that this is an optimal setting. And if it's not an optimal setting, lab technician again advances the jaw incrementally by 1 to 2 millimeters, and we see the best results.
May I ask you a question?
Yes.
Do you notice that you have molar distalization then? How do you prevent the maxillary molars from distalizing? Because in orthodontics, that's what we're using it for. So how do you prevent space from opening?
Yes, we actually do notice it. Luckily, I don't see that often. What on every single patient, excellent question. I do AP aligner. Let me show it to you.
And how about intrusion of the molars? Is that an issue also that you come across?
Not, it used to be with Herbst appliances.
Yeah, I'm talking about the Herbst, yeah.
Yeah, but so far, I haven't seen bad results. No.
Okay.
Not many. I didn't see any intrusions. Distalization, yes, I have seen distalization on the upper molars. But what I do religiously we make AP aligner. It's a wafer like that. I can actually show it to you. The patient, I boiled it. I boiled the water. I dip it, and it becomes, it's very like a very soft plastic, and patient bites into it, and it becomes a retainer. And every morning after removal of the appliance, patient bites into that wafer to realign the teeth, and bites hard into it for 10 minutes at least. And so far I noticed it's been effective. And what else, if any distalization or any changes would occur, this would indicate it right away, because that's how we can compare what's happening with the teeth, because it wouldn't fit anymore if the teeth position changes.
Right. So I'm sorry, I misunderstood. So it's a removable Herbst? It's not a fixed Herbst. It's removable.
Absolutely. The
okay.
herb supply, they only sleep with it at night because apnea happens only at night.
Right, but I guess my question then becomes, how are you able to advance it 1 millimeter if they're only wearing it at night? Like, that's how are the muscles deprogramming that quickly? I guess that's my
what I do. Let me show to you what I mean by that.
Sure.
Just a second. 1 second.
Thank you.
Just looking at this and given all the connections applies that she has, I don't think this is something that we could be doing tomorrow morning in our practices.
Yeah, no, it gets complicated. Yeah, this is great.
This is George gauge. This is that goes to the on the top.
Mm-hmm.
This is goes to the bottom. Let me show to you. I'm going to show on myself.
Awesome.
You bite on the top, making sure it fits.
Mm-hmm.
You bite on the bottom. See in this notch.
Yeah. Mm-hmm.
I protrude my jaw, lower jaw out. And that's how I see what is the range of my protrusion. So for example, I would start with, let me show, can you see it? Yeah. If I start with, for example, 5 millimeters and I was able to protrude 10 more millimeters. The jaw is flexible and the range of motion on average, it's 10 millimeters or so. So you can easily during the night keep patient's jaw 5 millimeters out like that. So when the patient places the appliance in, it keeps their jaw out 5 millimeters. And that's approximate position when the patient sleeps like that. Are you clear about that?
Yeah, no, I understand that. So I'm just looking at it from an orthodontic perspective.
Okay.
And when we advance on a herps, typically it's done on a growing child, but the idea of advancing it a millimeter with the shims is really once you've seen the outcome and where the muscles are. So I guess I understand how you would reposture the jaw edge to edge, but how are you making the determination to keep moving it forward? It's based on the patient saying, I didn't notice a difference. Okay, it's subjective.
It's a little bit, it's subjective,
okay.
But I try not to move it. I only move it between 50%, not more than 2-3 millimeters I advance,
Awesome.
not more.
Okay.
But, and then you always send the patient to a sleep study to verify this position.
Perfect.
You don't do it really that, you advance, unfortunately, you can't send to sleep study every time to your advance, unfortunately.
Right.
But you do you start with 50% and then you do a gradual increase, sometimes like to a 1-2 millimeters, and then you send patient to a sleep study. And then at sleep studies, at PSG study, they do verify is it an optimal position or not. And if it's not optimal position, they would protrude more. Usually on average, like they do it at like 2 millimeters at most. And it's enough.
Okay, thank you. That was helpful, thank you.
Is it clear?
Mm-hmm. Yeah.
It's very small. It's not it's not great. It's not a big numbers you're working with. It's the millimeters. Oh, about TMJ issues. Yes, it's a question. It was interesting, actually, a number of studies. And because of the advancement of mandible, a lot of people are concerned about TMJ issues. If the TMJ possible to, you know, to develop TMJ disease or exacerbated. What happens, it was a big study actually done, and I actually can get back to you with the study. And during the patient, it was a big study, approximately like 300 patients participated, and during the first week, approximately 25% of patients felt some discomfort or stiffening of the lower jaw. And by the way, we do give patients exercises for the time being. For approximately 2 weeks, they do exercise to stretch the joints a bit and to relieve some tension in the muscles. And after a month, people did not experience, who had initially problems, they did not experience any problems after 4 weeks. And even with patients who did have problems with that with TMJ disease, they had actually relief, because first the muscles were maximally completely relaxed. You can't tense your muscle while wearing this appliance. They're quite relaxed, and the joint actually did not have any, like, the joint was intact. The appliance cannot displace or damage the joint. So the appliance, the conclusion of the study was that the appliance did not aggravate the TMJ and did not cause any problems. And it was a long study. I have to get back to with the study, and it's not only one. There were a couple of studies done on this, but that was like very conclusive and very widely accepted research.
So we're actually in the Q&A segment of our presentation. I have a few announcements to make. If you guys can hang in there for another few minutes, we're going to send out the attendance form through the chat room, in which case you guys can sign up for the attendance. There are some questions that are coming through. How about we call out names and have them read the questions out loud? I know Alan just sent a question. Alan, do you want to unmute yourself and read the question out loud?
Sure. It was just the study that Dr. Cohen is talking about. There was actually a meta-analysis and a systematic review done in 2019. It was done in Sleep Medicine Reviews. So that's the article that she's talking about, that showed a little association between the appliances and TMJ problems. The correlation was not strong. That's what they showed in that study. I do actually have a question which I didn't put in there for Dr. Cohen. Actually, if you have any, if you're okay with answering this. I mean, are there any sort of objective indicators for non-responders? You know, sort of anyone that you see them first, they're sent to you for consultation, and you say, well, you're not going to respond to oral appliance therapy. It's sort of a contraindication in your case. What are some of the red flags sort of that you look for and say this person is going to be a non-responder? Let's move on. Let's think about something else.
Number one red flag: if a patient is not very educated and very close-minded. He thinks about, oh, you know, it's so difficult, it's awful, I'd hate it. And previously I used oral appliances and they are horrible and I can't use them. this would be the red flag for me not to even start. I don't even start patients like that. Because if they're not willing to listen and actually practice using the appliance, it's going to be just very discouraging for them and for me. So I say, you know, maybe you should wait a little bit, and whenever you feel comfortable, we'll start again. And we're not going to initiate any oral appliance procedures at this point. It's number one. Number two, patients who are severe, really severe, who have AHI 70 and above, and I see quite a number of them. I really try to sway them toward CPAP machine. However, unfortunately, some people don't want to use CPAP regardless, because they, they just have a girlfriend, they travel a lot, and CPAP for them is not an acceptable treatment. So,
are there any cases that you? Are there any cases you refer out for surgery? I'm an oral surgeon, actually. I do surgery for sleep apnea.
I want to jump in here for a second.
So it's a loaded question.
I'm going to jump in for a second. I know that we talked about a few times that this is part of a series of lectures, and we talked about orthodontics. We talked about, of course, prosthodontics in this case. And in the lecture that Gail gave, some cases were being referred out for oral surgery, and Alan does a good number of orthodontic surgery. He's part of our group EOI. And
that's wonderful to know that, I actually would love to use you, because some patients who are severe, they are willing to try this route, and I would love to send them to you.
Absolutely,
Yeah?
anytime. Thank you.
And tell us about when you come in as a surgeon. When do you exhaust the non-surgical approaches, and when you offer surgery, or where you make that division between, hey, let's try non-surgical versus this is should get surgery and it's a great benefit for them. How would you make that decision as a surgeon?
So to be honest with you, the decision is often made before they get to me. I mean, the patients are often referred as a last resort, which, it's understandable. People think of surgery as invasive with possible complications. Absolutely true. There are complications of non-treatment as well, or of delaying treatments. Unfortunately, when it's not out of the ordinary that I'm referred a patient that is so far along in their disease process that they often become not even candidates for surgery, because they have significant heart failure from long-standing sleep apnea or other problems. So if I get the opportunity to see them earlier, that's fantastic. And that's those are the people that really, really benefit. And the cure rate for certain procedures is actually pretty high, maximum mandibular advancement being the highest cure rate, but I wouldn't say that it is a big procedure to undergo, okay? But if it's indicated, it is indicated. There are other procedures that are let's say, about 15 procedures that are performed for sleep apnea, and which procedure sort of depends on the level of the obstruction that's created. So if it's just base of tongue, you can consider something like a hypoglossal nerve stimulator, or if it's there are combinations of procedures such as a uvuloplasty or pharyngoplasty, which addresses the palate, with a geniotubercle advancement. Either procedure alone has a high failure rate, but in concert, it's a reasonable success rate. And it depends on the level of the obstruction or where the obstruction sort of comes from. So when I refer to a patient, I work with the sleep center to sort of determine that. And there are ways of determining anatomically, functionally, where obstructions occur, and what sort of would be the best course of action if they've failed other treatment modalities. And in fact, for many, if insurance is to cover it, most insurances require the patient to have failed CPAP therapy for at least 3 months before they'll approve a surgical procedure for an adult. We're talking about here, not for kids. Kids are a little bit different. So yeah, they require at least 3 months of failure before you can proceed to surgery. But yeah, oftentimes the decision to go to surgery has been made before, or the failures have been made before the patient gets to me. Does that answer the question, Nima?
Yes, thank you so much. There was another question by Jonathan, but before I go to that question, I wanted to say, some people have to get off at 12 o'clock, whether it's lunch or the next webinar is starting for them. I put in a link in the chat room that's for attendance. You need to put in your name on that and hit submit so we know you're here, and that's how you get your continued education credit. That link stays open till tomorrow noon, so please try to use that. Question that came up from Jonathan was that, Jonathan, if you can unmute yourself and ask the question, and I think we had spoken on off the screen with Gail and Rita, the oral surgeons, not the orthodontists, when you are doing your screening during the routine recall, if there are any red flags that you could see that you could help the patient get screened more appropriately. I know there were check boxes and surveys that we've distributed this morning, and Ilana alluded to them. But are there any red flags that you recommend, either during the phase of development or later on as an adult, that you could just look at them and say, hey, maybe we should look into that further?
Oh, so hi. My question was just as a beginner, what would you recommend as like the first thing, an easy first step when we go back to the office, quote unquote, tomorrow? What would you suggest we add to our protocol? Or what are the easy things we can look for and then determine? Like, I've never sent the patient for a sleep study. Do I say, hey, you should go talk to your physician or go find a sleep medicine doc? Like, what's the appropriate first steps as we're going down this journey of learning what sleep dentistry?
Does Rita or Gail or Kathy, any of you, if you guys want to respond to that? I think whoever feels appropriate.
Yeah, so you have to refer the person back to their physician, because we are, I mean, at least me, because I'm not a physician. Alan is an MD also, so he can do that. But as an orthodontist, I can't refer for a sleep study. We have to refer them back to their physician.
Before making the referral, I would consider applying some of the screening that we learned about. The stop bang questionnaire is a very easy, quick questionnaire. It has a pretty high sensitivity for obstructive sleep apnea, depending on the score, of course. And there's a website where you stopbang.ca, where you can actually do it right on the website.
Everyone a sleep bang? Alan, you're not suggesting give everyone a stop bang. You don't give everyone a stop bang screening. Someone who you suspect.
Well, I'll be quite honest with you. Two things about that. So, when I work in the hospital, the answer is yes. I give everyone a stop bang questionnaire.
Okay.
And everyone that's being sedated, which I do regularly, definitely gets a stop bang questionnaire because it has an impact on sedation. Okay, so that's one thing. So yes, a lot of people I do, but having said that, if you read the stop bang questionnaire, there are just certain red flags on there. Obesity. It's not that hard to see if someone's obese. If they're male, it's not that hard to see if they're male. Their neck circumference. Their just ask them any daytime sleepiness. It's very quick and easy to get I'll say a quick and dirty stop bang questionnaire. Not a true number, but that'll tell you whether you need to go on and actually do a stop bang questionnaire, and you refer either back to their physician or to a sleep center and say, they have a stop bang score of, let's say if they're a 7, the chance of them having sleep apnea or some form of obstructive sleep apnea is extremely high. So it is something that you can,
And there's always Kathy. You could always get on the phone with Kathy and ask her what you think. Kathy, go ahead and give us some thoughts.
Usually in dental practice, because I speak like from the point of view of dentist, most common questionnaire actually it's Epworth we use. Granted, it's not exact, but it's something, and because it's still you can't make diagnosis on the base of the bank test. It's a still questionnaire. It's not exact. We have to rely mostly on the. We refer to the physician and see the result of the sleep study. And
okay,
I've never like just like from the point of view of a general dentist, I've never seen anybody to use stop bank test in an office. It's usually Epworth.
I'm just curious from the group. Has anyone? Do the physicians know what to do? The general physicians, when someone says, "Oh, my dentist said I might have sleep apnea," like, do they
So the answer to that
routinely
is
send patients for sleep studies?
The answer to that is it depends on who the physician is. And if you have, for example, I have a patient who I feel has a malocclusion. I know Rita and Gail are the ones that I want to call. So if this is something that you are interested in and that you want to be able to deliver that service to the patient, you really need to make friends with some referral that you want to work with. You don't just pick up a call physician and say, hey, you have an MD and I'm going to send it to you. I'm going to say, who is doing sleep medicine in my circle of connections that I have? So in my case, it would be Kathy. But there may be other people that are doing that and you want to send it to a sleep specialist that can help you about that. I do want to say two other things. Next week, we have an infectious diseases specialist. If you didn't hear this at the beginning of it, there is an infectious diseases specialist that's coming on, and I think that would be most appropriate right before going on to opening some of the offices. And I think Susan Siegel has a question that she wants to ask, and Jennifer Bestur had some comments to make that she wanted to make, and Aaron Raziel as well. So I don't know who wants to go first. Maybe Aaron, I think, go first, Susan second, and then Jennifer, you go next afterwards. Aaron, if you're on, go ahead and unmute yourself and ask the question.
I just wanted to interject for a moment. With the cooperation of the physicians, I've been doing this for 5 years. I've had a lot of difficulty. A lot of physicians aren't interested in getting involved. They don't want the responsibility. And then a lot of pulmonologists want to make their money on the CPAP machines. They're not making money on oral appliances. I do have a pulmonologist here in Brooklyn who's very cooperative. He's on Kings Highway, and he will give the prescriptions, once he's evaluated the patient, as long as they're not severe. He will give a prescription and he'll give his chart notes and, the sleep study. He'll give you everything required to get approval from the insurance company.
Thank you, Aaron.
All right. If anybody needs his number, I'll be glad to give it to you. But he's here in Brooklyn, and otherwise, I've had difficulties with other pulmonologists. So I don't know what the experience has been with other people, but
can I add a little?
Sure.
You have to work usually with physicians who are certified in sleep medicine, number one, and you do need to establish a rapport with them. They have to know you. Otherwise, I don't believe it will be easy for you to communicate.
There is a board of sleep medicine, right? And you could most likely log in there and look at their directory and see who's in your neighborhood, and then start the due diligence process and ask for people who are in your circles, what do you think of this person? Not everybody's practice is geared to that. Like, I just do endo, even though I know how to do crown. There's no way I'm doing that. So just because they're a physician doesn't mean they're focusing on that. Try with sleep medicine Board of Sleep Medicine. And if you don't have if you have a hard time finding that link, I'm sure Kathy and I can send you that link.
Absolutely.
Susan,
They actually have to be board certified sleep physicians. It's best if you start with people like that.
Very nice. Susan, you have a question for us, Susan Siegel.
No, it was an answer to the other dentist before. I screen all my patients when they come in for the hygiene visits. I give them the sleep apnea form and discuss the, issues that they're having if they score high on it. And I either refer them back to their physician, or I suggest they speak to their physician first. And if not, then I'll give them the name of a sleep doctor.
Thank you, Susan. Jennifer Besser, you had comments or questions?
Well, I guess I can offer a little bit on some of the questions that came up. One was regarding TMJ issues, and part of the problem with that is looping them all into one giant mass of TMJ issues. I think you want to be very careful not to make a mandibular repositioning device for patients with an unstable joint. Muscle pain can certainly be dealt with, but anybody with an unstable joint, there are exceptions. If you know that bringing them forward is going to help with their condition, then obviously that's something you can do, but you definitely need to have a good understanding of that. There was also a comment about tooth movement, and I will say that without fail, given enough time, every patient using one of these appliances will have tooth movement. Regardless of using the AM aligner, you're still going to get changes in the inclination of the anterior teeth and spacing behind the posterior teeth. Some patients will develop a lisp because of it. Very few, but some people will, and unfortunately, sometimes it's somebody who's on TV, and I'm speaking from experience there, and they suddenly develop a lisp.
It's a high possibility. Over a long period of time, you absolutely can develop spacing, particular in your front lower teeth. That's really that's what happens, but you have to notify patients beforehand that it's possible, and it's quite possible if you use it for years and years and years, obviously.
And then there was something about about the insurances, and I just wanted to stress, especially with Medicare patients, the oral appliance therapy is considered equivalent therapy to CPAP. And for that reason, with those patients, if they have had CPAP or oral appliance therapy within 5 years, they cannot have the other covered by their insurance. So it's something to be aware of in either direction, because if you have a patient coming to you who's had CPAP, they won't get coverage for the oral appliance. And the other direction, if you think they may not be a candidate, and I know there were some questions as for who may be a non-responder. There are some indications for responders and non-responders based on a sleep study. Just as an example, if the apnea is positional, if it's worse on their back, that's a good indication for oral appliance therapy. If it's worse in REM, that's another good indication for oral appliance therapy. That's not to say it won't work in the other cases, but it's less ideal. So if you have a patient coming to you for first-line therapy, and you think they may not be a candidate for oral appliance therapy, they may not benefit completely from oral appliance therapy. If they have insurance that will preclude them from having CPAP, you do want to keep that in mind. And also from a reimbursement standpoint, understanding that it may not be reimbursed if they've already had CPAP therapy. And the same for some commercial insurances where they have a global cap on what the insurance will pay for all of their therapies. So if they use that up, they won't be able to have the other therapies that may come further down the line.
Let me jump in here for a second, Jennifer. What we want to do in this forum, and that is very good practical information to give us with insurance, we want to increase the number of tools we have in our toolbox as far as what therapeutics we can deliver to our patients. Now, it may be that they don't qualify or they will not qualify down the road, but I don't think it necessarily means that they can't have it. Everybody can have whatever they want to. The question is, will they be willing to pay for it? And
that's exactly what I'm saying.
Right.
They just need to know up front. And I was just answering answering a question that came up on the things
to add something
it.
to what you were saying, Dr. Basur. So that was the one that was asking about non-responders. I think you mentioned positional. I believe, and correct me if I'm wrong, sleep apnea that is associated with primarily soft palate as a source, or with severe obesity. Those are also non-responders to oral appliance therapy. correct me if I'm wrong, but I think those are the other two that are, those are the two scenarios that sort of.
I believe that's correct. I mean, I'm not looking at it obviously right now, but I believe that's
severe
also on the list
obesity.
for,
Yeah.
Well,
yeah, the severe obesity, anyone with the BMI of like in the 40s.
They're going to be less likely to respond.
And those with very, very long, soft palates, because the positioning of the jaw isn't
going to change that.
Or those that have multiple levels of obstruction, including soft palate and collapsible airway and base of tongue and combinations. Those are the ones, and you can parse some of that out from the sleep study. Some of it are non-responders, and of course, anyone with central sleep apnea is going to be a non-responder as well.
Which is a good point as well. With central sleep apnea, oral appliances can actually make central sleep apnea worse, which is one of the real reasons why patients need to go back, especially if we create silent apneas.
Yes, that's very true.
Okay, let's circle back to Valentina Listova. Valentina, thank you for directing the course there. I know you've spent countless hours on the back end, going back and forth with Kathy and Ilana and trying to put this together. I want to turn back to you and hear your thoughts, any concluding remarks that you have. For the people, before I get off, for the people who are curious, there will be an email going out within the next few days that will have the name of all the panelists there, where they're working. Alan and Valentina are both with us at EOI. Kathy has her own Sleep Center, Study Center. And without any further interruption, Valentina, it's yours. Thank you.
Thank you very much, everybody, for your attention. Just wanted to again thank Ilana and Kathy for their participation. If you guys are interested in further exploring this topic, let us know. Maybe we can send you some more materials, links. If you would like to know more about surgical options, like we just kind of touch base on that, or maybe we can get somebody to talk about insurances. So just let us know, and I appreciate your spending your time with us today. Thank you, everyone.
Thank you so much.